Okay, I think we're ready to get started again. So it's really a great pleasure to reintroduce Dr. Bakri El-Sheikh, who helped us start the program back a couple of days ago in his discussion about multidisciplinary care, and is here to discuss the evolving phenotype in terms of walkers with spinal muscular atrophy, and is paired up with Dr. Jackie Montez from Columbia, who is obviously one of the deans of physical therapy in the spinal muscular atrophy field, and really launched the whole idea of these CME courses. And we are very grateful to have you both here today. So I guess, is Dr. El-Sheikh going first?
Thank you, Dr. Day.
Dr. Montez, excellent, thank you.
No, thank you, Dr. Day, and to all the organizers for this opportunity to participate in such an exciting event. It really is a privilege to present on this important topic, evolving phenotypes, with a focus on walkers across the lifespan. So I'm Jackie Montez, as Dr. Day noted, at Columbia University. I'm a physical therapist and clinical researcher, and my esteemed colleague, Dr. Bakri El-Sheikh, professor of neurology at Ohio State University, will join me in this presentation. Here are our disclosures. So for this talk, we plan to review the natural history of SMA with a focus on walkers across the lifespan. Then consider changes in disease trajectories with treatment in infants, children, adolescents, and adults. And finally, we will highlight these evolving phenotypes using patient vignettes. The natural history of later onset SMA, which encompasses SMA type 2 and 3, has been well described. As mentioned throughout the course, SMA is a slowly progressive disease with losses of function over time that vary depending on SMA subtype and age. Further, we know that there are vulnerable time periods where greater losses in function are observed. In work led by Professor Mercuri, the greatest changes in SMA type 2 patients were after the age of 5 and during adolescence for SMA type 3. In this graph on the left, greatest declines in motor function scores on the Hammersmith Functional Motor Scale Expanded was seen between 5 and 15 years old, shown in orange for the non-ambulant, and somewhat later for ambulant patients, shown in blue. Similarly, in work done in the Netherlands, greatest decline in walkers were seen between 10 and 20 years, highlighted in the red and yellow lines, where steeper changes in the Hammersmith score for SMA type 2 occurred before the age of 10, highlighted in the blue lines. Recent work looked at the frequency of change on the individual items of the Hammersmith at 12 and 24 months in a large sample of SMA type 2 patients. In this figure, the left side of the bar graph indicates the loss of an activity on that particular item, and the right indicates a gain in that activity when it's highlighted in black. What I'd like to point out is items 18 and 19, walking with and without support. And that note, it's rarely achieved in SMA type 2 patients. So in the natural history of SMA type 2 patients seldom become walkers. Published this year, work led by Professor Mercuri, individual trajectories of motor function were evaluated in a large international cohort. This work confirmed disease progression in SMA type 3 depends on age at symptom onset, with type 3As, or those with symptom onset before the age of 3 years, showing greater losses or a steeper slope, highlighted in figure B on this slide, compared to type 3B with onset after age 3, highlighted in figure C. We see similar changes over time when looking at ambulatory function using the 6-minute walk test. In this graph on the left, change in distance walked on the 6-minute walk test was plotted for patients followed up to 8 years. Similar to the observations on the Hammersmith, we found greatest changes in the 11 to 19-year-olds with a mean loss of approximately 22 meters per year, compared to about 9 to 10 meters per year in the younger children and adults. In the Kaplan-Meier plot on the right, in work done by Dr. van der Poel and his colleagues in the Netherlands, we can see that the likelihood of remaining ambulant is greatest for those patients whose symptoms appeared later, as seen in types 3B and 4, highlighted in orange and gray. Treatment appears to change these well-described natural history trajectories. Since it was approved first, we have the most experience with nusinersen in walkers, but I expect more information on the other approved therapies are forthcoming. The graph on the left highlights the improvements on the 6-minute walk test in 14 children treated in the early phase nusinersen studies. The median improvement was approximately 100 meters over 3 years. That included older children and adolescents. In the Cherish Shine study, which only included sitters at baseline, some children gained the ability to walk during the course of their participation in the extension study. I'd like to share this patient vignette to highlight some of these observations. This boy in the video was enrolled in the CS2 open label multiple dose phase 2 study of nusinersen. His symptom onset was 12 months and was diagnosed with SMA type 2 at 15 months. He has 3 copies of SMN2. He was enrolled in the CS2 study and received his first dose at 2 years old. He achieved the ability to walk at 4 years old. This video highlights his performance on the 6-minute walk test over time. We saw his first test, he walked 50 meters. Now, making progress on his second and third tests, he's up to 125 meters. He continues to make gains. As we see here now at 7 years old, albeit not big gains, he's now walking 190 meters. And then later, at 8 years old, he makes even more progress, now walking 220 meters. You may appreciate some changes in his gait over time. Now, at 8.5 years old, we start seeing some decline, and now he's walking about 165 meters. So as he approaches adolescence, it'll be important to continue to monitor him, as we know this will be a vulnerable time period. The next vignette shows our experience with SMA type 3, with an SMA type 3 patient who we had followed for more than 10 years. Remember, the graph on the left that I showed earlier highlights the vulnerable time period between 11 and 19 years old. We found losses of approximately 22 meters per year on the 6-minute walk test in the natural history of the disease. On the right is a graph of the 6-minute walk test performance for this individual over time, beginning at 11 years old. You can see that he was declining in function beginning at age 11. At 14, he was enrolled in the single dose 1 milligram phase 1-2 CS1 study of nusinersen. He was continuing to decline until receiving a higher dose in the CS2 study, then followed by the currently approved 12 milligram dose, where he began to regain walking function, as demonstrated on the 6-minute walk test. Since he seems to have largely stable walking function, was able to attend college, live in the dorms, and he remains an independent ambulator. Now I'll turn it over to Dr. El-Sheikh to discuss the evolving adult and infant phenotypes.
Can you hear me now? Hello?
Yes, we hear you
Oh,
well.
great.
Thank you.
Excellent. Okay, thank you. Thank you, Dr. Montez, and hello, everyone. And thank you, Dr. Day, and all the Stanford team for a great and really rich program. I'm truly honored and glad to take part. So to continue the journey that Jackie started across the lifespan of walkers, with SMA, I wanted to start by highlighting some data on strengths and motor function among SMA patients who retain ability to walk to adulthood. So the left graph show data from 33 ambulatory adults with 5 QU SMA and a mean age of 37. The muscle strengths of the elbow and knee flexion and extension bilaterally were measured using maximum voluntary isometric contraction testing, or MVICT. The box plots illustrate a Z-score, or a standardized MVICT score obtained using comparison.
Bakri, we're seeing a static slide. So I think, I'm not sure. We're seeing it progress. So maybe you have, there we go. Okay, thanks.
Okay, so the left graph is from 33 ambulatory adults with 5 QU SMA and a mean age of 37. And as I mentioned earlier, the muscle strength was tested using MVICT scores. So the box plots illustrate a Z-score, or a standardized MVICT scores obtained using comparison with predicted scores from healthy control data, according to age, sex, and muscle group. And what I want to highlight here is the data showed severe weakness in all the muscle group tested when we compare ambulatory adults with SMA to healthy controls. The graph on the right is from the study by Wadman et al., who evaluated also muscle strength using a cross-sectional approach to investigate a cohort of 180 patients. 108 of those patients were above the age of 18 years, and noting a mean loss of about 1 point per year in a sum MRC score from 34 muscles. So the study also noted some variable patterns of decline in all types of SMA, including SMA type 3A, B, and some with type 4. So regarding walking and motor function in adults with SMA, there are several studies addressing that. And to highlight a few of many, the graph on the left shows data on the probability of remaining ambulatory versus disease duration in years on the x-axis. And one can see the contrast between SMA type 3 versus SMA type 3A versus SMA type 3B, with increased likelihood of losing ambulation in those with type 3A. The graph in the middle is what was shown earlier by Dr. Jackie Montez, and it does shows an annual average decline in the 6-minute walk test distance by about 9.3 meters in those over the age of 20 years. And the last graph on the right shows some longitudinal decline in Hammersmith functional scale is expanded in the various SMA type. So collectively, the data support that SMA is a progressive disease in all ages and types, and that's including the adult SMA population. So let me start with a patient. This is a 48-year-old patient who has symptoms onset at the age of 26 years. He did develop some leg weakness and basically presented with some difficulty going up steps. He was confirmed to have SMN1 gene deletion and 5 copies of SMN2, and diagnosed with SMA type 4 and followed in the clinics for a few years. He also was diagnosed with anxiety, hypertension, obesity, and sleep apnea. So following the FDA approval of nusinersen, he asked to be started on treatment and citing functional decline over the years. So prior to the treatment, if you can look at the data comparing the change in his 6-minute walk over 10 years period. So you could see the 6-minute walk 10 years prior to his baseline assessment was 459 meters. And at the time of before starting treatment, he was at 387. Similarly, his activities of daily living measured by the SMA functional rating scale dropped from 40 to 30. And there is also a trend there on his forced vital capacity. So accordingly, we decided to proceed with treatment with nusinersen. And so far, he's shown some improvement in his 6-minute walk and his SMA FRS score. You realize his 14 months visit was done remotely because of the corona. And you could see he remained stable with his activities of daily living or the SMA FRS. So there is obviously an increasing number of publications on real-world data on adult response to nusinersen treatment. The largest of those cohorts is the cohort from Germany by Tim Hagenacker et al. And this is some of the data shown here, picked out mostly on the ambulatory adults, showing that are supporting the responsiveness to treatment in adults. And obviously, that study showed that there is greater improvement correlated well with lower disease severity at baseline. Obviously, not all patients in treatment will show improvement. Some may stabilize, and you might have some who decline. Also, I want to note here that the recently approved oral agent, the small molecule risdiplam, for use in all adult for all patients, including the adults. There is limited data on the ambulatory adults so far. However, the Jewelfish study, which was the open label one in US and Europe, included 174 patients ages 6 to 60. And there is 16 of those who are ambulatory based on the data that was presented in the World Muscle Society. So the last meeting. So I brought this slide again because there was a talk as well about the combinational therapy. And this was data from OSU that was presented by Dr. Dave Arnold in the last Cure SMA meeting. And basically looking at cross-sectional data of adult patients who were treated with nusinersen. And that cross-sectional analysis showed that there is no difference in the percent decrement obtained using 3 Hz repetitive nerve stimulation of the spinal accessory nerve. And significance was using the standard cutoff of 10%. That's regardless of disease severity of use of nusinersen. This actually makes a neuromuscular junction another potential target for combinational therapy. It will be also interesting to see if there is difference when based on the different therapies. So here is another slide, and basically this is the data that was well covered by Dr. Richard Finkel and Eugene Mercuri on the first day. But all what I want to say is to highlight that the impact of new therapies on non-sitters, although rare, but a walking milestones can be reached in that age group. Similarly, among the pre-symptomatic infants who were treated with various agents, we're seeing some data on the pipelines and some data that showed that we're seeing walkers among those with 2 SMN2 copies. So this slide essentially captured the big picture of the changing phenotype in SMA, with us, with the different treatments, seeing walkers from all types, including those non-sitters and sitters. So here are some take-home points. And it's evident that new therapies positively impact ambulation over time and provide potential for some with pre-symptomatic and symptomatic SMA type 1 and type 2 to achieve ambulation. Moreover, adults with apparent mild phenotype may show meaningful improvement with treatment. Lastly, there is definitely a need for additional data to address gaps in knowledge, including better understanding of the evolving phenotypes, the difference in response to the various therapies, durability of the response, and the role for combination therapy. And thank you very much.
Well, thank you very much, both Jackie and Bakri. This really provides us with a firm foundation of our understanding of walkers and will carry us into the breakout sessions where these can be discussed in a little bit more detail by the different disciplines.